Hey, so what we want to do is start to take a look and kind of review just a little bit. This is a really quick review. It doesn't take from you going back and reviewing all the information and data that you've gotten, but I'm trying to help you focus just a little bit because it's a lot of information for this exam. So let's get started. So I listed 5 medicines, and I know there's lots, and please do not learn medicines, but I wanted to help you focus a little bit because it's so much information. So if you look at dantrolene, this is the drug of choice for malignant hyperthermia. Go look back, what is the drug, what does it do, and how does it affect the body with malignant hyperthermia? It's the drug of choice. It's the drug we use to treat malignant hyperthermia, and you need to understand what malignant hyperthermia is so you can understand what dantrolene does. Aluminum hydroxide is an antacid class. You need to go and look at that. The thing about antacids is they do one thing. PPIs, the proton pump inhibitors, they do something else. But one thing about those meds is they affect different things. There's calcium involvement, there's magnesium involvement, so our fluid and electrolytes can be off from them. So go review those medications, know not only the brand name, you need to know the name of them besides brand, because that's what you're going to see on your boards. And then of course Epigen, and Epigen we're going to see it in other things. It's given for other reasons, but go ahead and look that up, because why do we give it? It's going to help build red blood cells, and we usually give it pre-op, way before their surgery, so that they can start to build more blood, so that they hopefully won't have to have a blood transfusion. So HIV, I listed some things on there. PPE is one. You need to go back and review what kind of PPE you use with an HIV patient. Always remember to teach your patient to wear a condom, period. It doesn't matter who has AIDS or HIV and who doesn't. Even if both partners have it, they still need to wear condoms for safety. Anal sex is oral sex, blood transfusion, IV sticks from contaminated needles, and other ways things can happen where you can be more prone or prevalent to contract HIV. But just so you know, anal sex still seems to be the #1 or the most at risk. People that have anal sex are more at risk or a higher risk of getting HIV or AIDS. So the other thing you need to think about is same-sex anal sex, and so that seems to be more prevalent, but that isn't limiting to, and I don't want you to always limit that, because that's something that our society loves to do, because you could have someone who was very involved, heterosexual couple, that prior to them meeting each other, that one or the other was in a same-sex relationship, and a homosexual relationship, and because of that they could spread it. But it isn't just a homosexual disease anymore, it is a disease. Arthur Ashe, the famous tennis player, he got it from blood transfusions. He was a hemophiliac and had to have blood transfusions a lot. And so there's ways of getting it. And one thing, it was the death disease back in the 80s when it first came out, and everybody was scared to death. But we have come a long ways. There's tons of medicines. Look at the famous basketball player. I can't think of his name right now, but he actually is HIV positive, and I think he got it with an affair with someone that had it, that gave him, it was some woman he met up with while he was out and about traveling across the United States playing professional basketball. But he's a great spokesperson now, because he's been taking the medications, and they are working for him. He has been very healthy, and he has had HIV for a very long time. And remember that HIV is the start. It's full-blown AIDS that you're concerned with, where you start to have all those other things that happen, and that's what usually will take their lives. It's not the HIV piece. We're in the beginning piece. It's the AIDS piece of when things go a different level. We check lab work all the time, because what's our biggest fear? Is it attacks the immune system, right? It attacks where we can't fight off different infections and different things going on. So we want to look at the white blood cells because they're indicative of infection, CD4s because they're the ones that are attacked for HIV patients. That's what HIV, it attacks those CD4s, and that's why we can't fight off infection. And then, of course, there's a lot of other things we need to look at because HIV wreaks havoc on the system, in the meantime, and the medicines. If we're giving medicines that have to be processed through the liver, through the kidneys, we need to be checking renal function and liver function. And just remember, if you have decreased renal function, we're not going to filter correctly, right? We can't filter things like we should. Our electrolytes will be off, those kind of things. If we have elevated liver enzymes, we can have bleeding risks. So those are the things we need to think about as we're looking at labs. When you see renal, you should think filtering. You should think electrolyte issues. When you see liver, you need to think filtering of medicines, processing, because that's what they do, but think bleeding. Because usually if we have elevated liver or anything, we're going to have bleeding issues with these patients. And any patient, I should say. So pre-op, a few things. Let the surgeon, of course, explain the risks, the surgery, any post-op expectations for the patient. They need to know that they can't walk for a week. That needs to come. The surgeon needs to discuss everything about the surgery, what's going to happen, any risks, of course, and go through that, and then answer any question that the patient has. If you have a patient who doesn't understand or questions or something, it is not at your place as the nurse to explain it so that they sign that consent. Now afterwards, if you go on down and they're asking a ton of questions and they still don't understand, you can call the surgeon and say, they really have a lot of questions. I think you need to come back up and talk to them. It still isn't our place. Now there are times where we can stand in there and the surgeon will say something and the patient's just like, what? And you can say as a nurse, this is whatever, but it's always good to do that in front of the surgeon so that he can say, yes, that's exactly what I mean, or no, this is what I mean. Don't be the one to take it upon yourself to say, this is what, just because you think you know. They sign that consent and they didn't know all the risks and something happens, then guess what's going to happen? They're going to come after you. And you don't want that, and you don't need that. And as a patient, wouldn't you want the surgeon to tell you? That's how I look at it. I would want to know the expert is telling me things. So just remember that. The consent needs to be signed before any sedative is given. And you want this consent signed when all the questions have been answered. It's not a time to go coerce a patient into signing that consent or the family to say, just sign it, Dad. You don't need to know what's going on. And we've got you taken care of. No, if he has questions or concerns, they need to be answered by the surgeon. Call the doc. Just say, hey, you can call his nurse. This patient in room whatever has a lot of questions. I know that you've already come up to talk to him, but you probably need to come again. He has not signed his consent, and they'll come because they want to do the surgery. Also, all vitals are checked and any abnormal labs or vitals need to be called to the surgeon. So you want to look at your vital signs. We want to look. If you've got a super high blood pressure, you need to call the doctor. If they've not been running a super high blood pressure, you need to call them and say, hey, just by the way, his blood pressure was 120 yesterday, but it's 180 today, or 180 prior to going to surgery. And it could be white coat syndrome. It could be fear of going into surgery itself, just different things. So any of that, temperature, if you have an elevated temperature, it's indicative maybe of an infection. Do we want an infection prior to going to surgery? No, of course we don't. So those are things that you want to call. Labs, if I have abnormal labs, if I have a low hemoglobin, it means I'm not going to have great oxygen carrying capacity. I'm also might be volume low, so I could have trouble with my blood pressure and things like that. So the doctor might say, fine, okay, good for letting me know. And we're going to give a unit. Is he typed and crossed for a unit or 2 units? Please have one sent to the OR so that they can go ahead and give him a unit of blood because his hemoglobin's low because he's going to lose blood during surgery. So we want to make sure. If the blood sugars are out of whack, they need to be controlled. If he has super elevated blood sugar, they just need to know. It doesn't mean they're going to cancel surgery. It just means that they're going to treat it accordingly because when we put stress on the body, things can happen, and one is sugars. Sugars can go up. If they're taking steroids, corticosteroids, we need to let the doctor know if the doctor's not aware, because they actually suppress the immune system. They'll raise their blood sugars. Steroids can do a lot of bad things, so we need to make sure that the physician is aware. You know, back to H&H's, livers, enzymes, kidney labs, renal function. We need to know all of that. Anything that was not, if you have a lab here and right before surgery, the lab's here, this needs to be called. If you have a lab here and the lab is here, you don't need to call. But if you've got a heart rate that's 100 and now you have 180 heart rate, needs to be called. Anything abnormal, the doctor or the surgeon needs to know prior to going into the OR. You don't want to get a patient down and get them all prepped. The doctor walks in and they're looking at everything, or they start the surgery and all of a sudden this patient crashes because they're not aware of what's going on. So it takes a village, guys. So post-op, remember to not change the dressing. The surgeon always changes the first dressing. If you've got excessive bleeding in that, over that dressing, just reinforce it. Take gauze, go over it. You can take your Sharpie and circle it. Watch it. Sometimes they'll come right out of the OR and there'll be some blood on it, which is normal because they've cut the body. It might bleed. You just take your Sharpie, circle around it, and then you look at it and you watch it. If it goes outside of your circle, the Sharpie, then it means they're bleeding. Then you're going to call a doctor. If they don't, or it's just a minute amount around and then it stops, then you think, well, that's just an initial superficial bleed and that's stopped. It's now starting to heal itself slowly. So if you've got one, it bleeds, it saturates through, circle around it, watch it. If it gets going outside of that circle, call the doctor. That's indicative that it might be bleeding, but you don't change it. You're not going to take that dressing off. You're going to reinforce the dressing. Depending on the surgery, they might have different post-op complications. So there's just different things that can happen. Just remember that. If we're doing an appendicitis, we're going in the abdominal, right, lower quadrant area. So if that's the case, then we're going to have different things going on, because it's different than if you did something with the nose or the sinus cavity or the spinal cord. So if we're doing it wherever we're doing, we're going to want to assess that area and think about those complications. One of the biggest complications of surgery post-op is hemorrhage, right? One is respiratory depression due to anesthesia, but hemorrhage, they can bleed because they've been cut and worked on. So if that's the case, you know, you want to make sure you understand. Let's just say they're having throat surgery, let's say tonsillectomy or something like this, or adenoids or something being worked on. And if they start to hemorrhage here, they're going to swallow because there's blood going down the back of the throat. They're going to get nauseated because we don't digest blood. They're going to start to throw that up. So you want to make sure you understand that. This area, it's going to get hard. Let's say they cut the abdomen. You're going to have, if it's bleeding underneath their internal bleeding, it's going to get obtunded. It's going to get out and hard forming. It's going to be tender to them when you palpate it. You're going to see blood. If there's an outlet where blood can come out, it's going to be coming out in that dressing. I had a gentleman one time, and he had abdominal repair, aneurysm repair, and he had not ruptured. He went in and had it fixed, and when he came back, his abdomen was pretty round, okay? And he had a lot of bleeding on his dressing. I circled it and everything, and I looked at it. The doctor came around right away, and I said, just FYI, he's pretty round. He's a little taut, but he's still soft, and I've circled around. Well, we noticed there's a little more, and he said, let's watch that. And I said, yeah, I will. I ended up calling him at least 4 or 5 times. Residents came. He was back in the OR. The residents came. They were not worried about it at all. I'm fighting blood pressures and heart rate and all of that on the monitor with drips. I'm trying to get his blood pressure up. In the meantime, that abdomen got bigger and harder and pale in color. And I was like, I'm worried about this. I'm worried about this. And I'm not lying. I think after the 3rd time the resident walked through the door, and this is legitimate time call, 3rd round I've called, I said, I'm very, very concerned. They come by. We're not worried about it. More or less, don't call us again. I said, you know what? I'm going to call the surgeon in the OR and let him know what's going on. So I called down to the OR. You know, you got to get strong, guys. I called down to the OR and I said, and he was mad. Surgeon was mad. He was screaming. And I said, listen, you had 3 residents come up and they've all just kind of blown me off. He said, they told me it's fine. They told me it's fine. Well, anyway, finally he got out of surgery, came up to see the patient, and he said, this isn't fine. I'm very sorry. You are very right, and you need to get him ready. We're going back down to the OR. He's bleeding. And so we whoosh, and got him down, and he ended up living. But I'm going to tell you something. It took me to sit there and call and call and call and finally call the surgeon directly, because I was like, no, this isn't right. That's a seasoned nurse. So just remember that. If you don't feel right about something, just keep on. Who cares? Let them chew your butt out, because guess what? You've saved a life, and that's more important. That gentleman lived to tell the story. Enough of that.